Hello, and thank you very much for joining us for our webinar on the topic of mental health and healthy minds. I'm Candace Critchlow, Port Coquitlam Community Police Services Manager, working as part of the Coquitlam RCMP Community Policing Team. We're excited today to bring you today's presentation as part of our 2021 Community Safety Webinar Series. I'd like to begin this webinar by acknowledging that mental health is a very dynamic term. It covers a lot of topics, and we've had a lot of great questions that have been incorporated into our presentations today in order to try and address them. So there won't be a specific Q&A period, but hopefully your answers will be provided throughout. The hope of this webinar too is to ensure that we are not only talking about mental health, about destigmatizing it and putting it into our regular conversations, but like also ensuring that you have the tools to be able to host a conversation and ensure that you can find the resources regarding the varying topics. So in order to help shed some light on this topic, we have our community partners. So first off, we have Andrea Ringrose. She is a director of campus public safety at SFU, Simon Fraser University, as well as a mental health first aid instructor for the Mental Health Commission of Canada, as well as a Canadian Mental Health Association certified psychological health and safety advisor, and the vice president of the Canadian Association of Threat Assessment Professionals National Board of Directors. She is widely recognized and is committed to increasing mental health literacy in public safety and strategies regarding security strategies that are rooted in over a decade spent with UBC psychiatry and GVRD health authorities on applied clinical research teams renowned for translating their critical research to practice. And most recently, as a member of UBC's Translational Psychiatric Genetics Group. She incorporates unique cross-cultural and interdisciplinary experience to develop creative people-centered solutions to emerging safety and security concerns, and seeks to enable a better understanding and appreciation of the complex human element in intelligence investigation, contemporary risk frameworks, protective security screening, and behavioral threat assessment and management approaches. Andrea is the founder also of a warmmeup.org, Vancouver's original sock and underwear drive for the basics benefiting those living with serious mental illness. Along with that, we also have, who was supposed to be Constable Scott Klein, part of our mental health unit in the Coquitlam RCMP. He ended up having to be on a call today, so we have a co-worker, Constable Habeeb Shah, and he's here today to introduce and talk about Coquitlam RCMP. So I know we're tight on time, so I just wanted to give a quick introduction to our lovely speakers today. So I'm going to let Andrea take it away.
Well, thank you so much, and thanks for inviting me in. It's yeah, I'm thrilled to be here. Well, thank you all for being here today. May the 4th be with you and joining us for some mental health literacy talk. Also, happy 70th anniversary to Canadian Mental Health Association's Mental Health Week. Their campaign this year, you've probably seen it on social media and elsewhere, is Get Real. And I hope after our short time together, why this is so relevant, why this simple campaign lands so heavy right now for people will really be evident. So I'm gonna try to give you a baker's dozen worth of information here in the next 40 minutes or so. We're gonna try to increase some comfort with mental health literacy related concepts, really get some of those terminology, the language down, and then introduce some interactive relationships, mental health, mental illness, stigma, intervention. What do these all have to do with each other? And of course, some of your questions that came in really centered around supporting people. Taking it from let's talk to let's talk about it and how do we talk about it, and mitigating risks. And by risks in this context, I'm not speaking about security risks or risks to public safety, but risk to persons, risk for relapse, risk for worsening of mental health problems. And the big elephant in the room is, why has COVID-19 negatively impacted mental health? And for some people, the question might remain, has it? We're going to touch on engaging with empathy, knowledge, and comfort some of the opportunities to develop those muscles a little bit more. And throughout the presentation today, I've tried to weave your questions throughout, as well as some of the resources you might not hear so frequently, and kind of what's next, what's looking ahead. There are a few things, because of the limits of our time and the scope of today, we're not going to really be getting into, and that's aspects of neurodiversity, dementia personality disorders, mild traumatic brain injuries, a lot of the other brain disorders and other things that do interact with individuals' mental health, mental illness. But that doesn't mean that they aren't a part of the conversation. It's just we're limiting our scope today, and unfortunately, we're not going to be getting into those topics in depth. So what is mental health literacy? Borrowing from health literacy and health promotion, it's the knowledge, beliefs, and abilities that enable the recognition, management, or prevention of mental health problems. So let's look at that. It's a challenge of existing knowledge, a challenge of existing beliefs, and a recognition of abilities that we need to develop to allow us to recognize, manage, and prevent mental health problems. So we have a couple of humble goals for today. We're going to try to chip away at stigma, and also try to increase in some ways help-seeking efficacy. You won't be able to diagnose a mental illness. Nobody's getting a certificate as a doctor of mental health literacy after our time together today. And to a note here, I want to clarify that I am not a psychologist. I'm not a psychiatrist. I don't work in a clinical mental health professional capacity. I'm a mental health literacy advocate and trainer, and work closely in the intersection of caring for persons, as well as engaging in public safety related work. And I'm a really strong believer that as we increase our community's mental health literacy, there will be benefits for all individuals' outcomes, both ourselves and others that we support. So by the end of the presentation, while you won't be able to diagnose, you may be able to recognize what basic knowledge and skills will better equip you to advocate for yourself and for others, and to assist someone experiencing mental health challenges or during a crisis. So mental health and mental illness, at times we hear individuals use them kind of interchangeably, but they don't actually mean the same thing. So let's take a look at this. Everybody has mental health, just like everybody has physical health. A mental illness is an illness or a disorder, just as people have physical illnesses or other types of disorders that affect the way that they think, feel, behave, or interact with others, engage with the world around. When we're talking about mental illnesses, these are illnesses that cause alterations in thinking, in mood, in behaviors associated with significant distress and impaired functioning. So this is where we are getting into disorder. You may also hear mental illnesses referred to as mental health disorders, mental disorders, or psychiatric disorders, among some others. Throughout the presentation today, you may hear me just referring to mental health problems. That is more of a catch-all phrase that may include both mental illnesses and symptoms of mental illnesses, which may not be severe enough to warrant a diagnosis, or somebody hasn't sought diagnosis, or it's not persistent enough to warrant diagnosis, but still there are concerns with mental well-being. But what is mental health? I'll give you a minute to just read through this. So mental health, which we all have, you, me, Candace, it's the capacity of each and all of us to feel, think, and act in ways that enhance our own ability to enjoy life and to deal with the challenges that we face. It's a positive sense of emotional and spiritual well-being that respects the importance of culture, of equity, of social justice, of the interconnections we have in our lives, and personal dignity. When we read this, we see how personal mental health is. We also might recognize that mental health is therefore very dynamic based on what is going on in our lives, what is going on for us. But we're all affected. We're all affected by mental health problems, and mental illness. Many people are functioning well within our community, even those with serious mental illnesses, professionals living with bipolar disorder, professionals living with schizophrenia that is under wonderful treatment. There are individuals in their career and in their relationships that despite a diagnosis of illness, they're still at work. In the workplace, for example, 23% of workers experience physical health problems that we actually know are caused by stress, anxiety, or major depression, while that might not be evident on the surface. Some of those reasons that it might not be evident is related to individuals' comfort or fear of others knowing that they have a diagnosis of illness, and the stigma still attached to mental health problems and mental illnesses. We also know that at least 20% of workers experience fatigue, sleep problems, headaches, and anxiety. And we know that at least 20% of all sick leaves are mental health related. These numbers, we believe, are likely low. These are reported numbers. The picture is most definitely much greater than this, especially during the ongoing COVID-19 pandemic. So what is something like a mental health first aid, a psychological first aid? Mental health first aid is the help provided to a person developing a mental health problem or in a mental health crisis. Just like physical first aid, this is the aid that's given until an appropriate professional is able to help or until that crisis is resolved. Similar to physical first aid, a mental health first aid or a psychological first aid has the aim of preserving life, providing help to prevent the mental health problem from becoming more serious, promoting the recovery of good mental health, and providing comfort to a person experiencing a mental health problem through non-judgmental communication, empathy, but when you hear the term mental health problem, what is your first thought? When you check in with yourself, what reactions do you have when somebody shows a sign of mental illness? Or when we may feel that we may be affected and that others may be noticing? We hear let's talk, but what we haven't done as good a job of is equipping people with the skills and knowledge and access to training about how we talk about it, how we receive that information. How can we better also acknowledge the importance that culture, equity, social justice, interconnection, personal dignity, persons' intersectionalities, reconciliation, diversity? How do we do a better job of integrating these essential foundations into the supports and interventions that are available in our communities? And when we are engaging with individuals about their mental health. Some of you may have seen the mental health continuum. There are various iterations you can find online as well if you Google this. This is a really important image. If you look at the x-axis, it's very different than the y, but they are interconnected. An individual can have a maximum mental disorder. So in this case, let's consider somebody with a diagnosis of paranoid schizophrenia. They may be way over in the maximum mental disorder. However, they may have really wonderful treatment adherence, self-care, supports, a lot of the other protective factors, and may have very good mental health. Here we see that the two are different, but very related. Similarly, we might have an individual with minimal mental disorder. They may not have a number of symptoms that persist for 2 weeks or longer, or months or years, but at the same time, they're not great at self-care. That burnout happens. They aren't sleeping well. They don't eat well. Maybe they use substances. They might not abuse substances, but they don't have a diagnosable mental disorder, but maybe they have poor mental health. We can all think of times in our lives where we've moved around this mental health continuum. And that is true for everyone, whether they are diagnosed with a mental illness or not. I am going to share with you a video here from Dr. Janine Austin, who is the head of the Translational Psychiatric Genetics Group.
I think in the context of our current global environment, whereby we're all under very unusual and stressful and difficult circumstances as a result of COVID-19. For sure, we're going to see that people are going to be struggling more with their mental health, and this is going to be for a number of reasons. We know that just the life events that, people are losing their jobs, family members or loved ones are becoming sick. These are incredibly stressful events that we are having to try to process and deal with. We don't have to be diagnosed with a mental illness in order to take actions that can be protective for our mental health. The analogy that I use with people when I'm counselling them about risk for mental illness is that we all have a mental illness jar, if you like, every single one of us. And that in order to be actively experiencing an episode of illness like depression or anxiety or what have you, that jar has to be filled all the way up to the top. Okay. And there are two different kinds of vulnerability factor that we can fill our jars with. There's these genetic vulnerability factors that we've mentioned briefly, and we all have some of those. Some of us are going to have very few, others of us are going to have an awful lot. Most of us are somewhere in the middle, an intermediate amount of genetic vulnerability. The other component, though, is environmental or experiential vulnerability factors. It's genetics and it's environment working together. And so what we're seeing at the moment is that everybody in the world is experiencing a greater impact of those experiential or environmental vulnerability factors. So perhaps we're going to be in a situation where more people's jars are going to be filling up all the way to the top, and they experience their first active episodes or symptoms of an illness like depression or anxiety. So what we can do still, though, is that we can make our jar taller. Okay, so the concept here is that there's the things that we think of as being protective factors, essentially, which you can imagine as being rings that stack on top of the jar, making it taller so that the jar can accommodate more of that environmental or experiential vulnerability without getting full all the way to the top, right? And so things that we know work really well as protective factors are things like sleep. Exercise is another thing we know. Nutrition, so good quality, regular eating if you can. Social support, finding more effective ways to manage stress can be really helpful. Spending time with a pet, or so it's trying to identify for yourself what are those things that you do that you notice have that sort of decompressing effect on your mental state, and trying to prioritize making time to do those things that we can still do.
I'm going to talk a little bit more later in the presentation about the mental illness jar and the specialist clinic that Janine, and when I was a part of the research team, founded, the world's first psychiatric genetic counseling clinic. And I'll touch on that later on. But let's look at COVID-19 and mental health. So new data from UBC and CMHA reveals a toll. This is the third phase of similar benchmarking since the onset of the pandemic. This was a sample of over 3,000 individuals across Canada over the age of 18 and over. The sample sizes across the provinces differed. Some of them weren't really significant sample numbers, but on average, they found about 77% of adults report negative emotions as a report of COVID-19 pandemic. I don't think that that's really surprising to us. But what we also see here is that overall 41% of Canadians report that their mental health has declined. So this is interesting. We have individuals that have reported in much greater numbers negative emotions, but only certain Canadians have reported that their mental health has declined. We'll look at what that means here. Negative emotion isn't necessarily a sign of poor mental health. It is very healthy for us to express ourselves. And when we look at CMHA's campaign this year, the Get Real, they're encouraging us to talk about how stressed we are, how sad we are, how hopeless we're feeling. There are very positive ways about interacting with unusual negative events rather than bottling it up. Now, 5 of the most common emotional responses to the pandemic across Canada, according to one of the lead researchers, Dr. Emily Jenkins, was that people were reporting that they're worried or anxious, that they're bored, they're stressed, they're lonely or isolated, and just generally feeling sad. But like I just said, good mental health is more about the appropriate emotional and behavioral responses to stressors and life events. Stressors and negative life events are normal throughout the course of our lives. How we engage with those, how we recover from those, that bounce back effect is really what we're looking at. And it's not about being happy. It's about our resilience and being able to overcome some of those inevitable negative experiences in life. Pandemic-related losses include loss of loved ones, the inability to mourn and to grieve in the ways that are culturally appropriate for our communities, losses of connection with others, losses of security. There's a sense of instability that has really come with this ongoing pandemic. The removal of measures, the reintroduction of measures, not knowing what comes next, week to week, month to month. And concern arises when challenging emotions interrupt our daily functioning and maladaptive patterns where thoughts of suicide emerge. Early in the pandemic, you might recall that BC Liquor was reporting sales that were through the roof. Individuals unable to socialize with their friends were at home drinking a lot more. And we've still seen that increase in consumption kind of remaining in place. So some of these maladaptive patterns, not exercising, finding other ways to do so safely outside when our gyms close, for example. And according to the research, suicidal thoughts and feelings in the general population has remained elevated. It's come down a little bit. It was slightly higher than this. It was 10% or higher in a lot of the polls that were taking place. So it has come down a little bit. But if we look at one of the pre-pandemic benchmarkers in 2016, that rate was observed at about 2.5%. So we are still seeing a worrying elevation there in terms of suicidal thoughts and feelings. So Janine introduced the mental illness jars in that short video. There are no genetic tests for psychiatric and mental health disorders, none that are reliable at this time. But genetic counseling at the ADAPT clinic is for anyone of any age who's diagnosed with a mental health or psychiatric disorder, and also for the family members of those affected, to try to understand kind of that why me, why not them? Why them? Why not me? Is it my fault? What are the protective factors for future? This is a free clinical service that's covered by MSP. One of the offerings that I wanted to introduce is it's not really well known. The wait lists are a lot shorter than some of the other mental health services. And like I said, it is free to anybody that is living in BC, covered by MSP. So I do encourage you to look into it if you yourself are affected or if you have family members that are affected. Now, what are the most common mental health conditions that we encounter, that we experience? Mood disorders, anxiety and trauma-related disorders, substance-related disorders, and sometimes the interaction of substance-related disorders with some of the others that we have listed here, and psychotic disorders. Now they're listed sequentially, but that is not to say that they occur in isolation. More often than not, for many of these disorders, individuals may be diagnosed with more than one. And unfortunately, suicide is a risk for all four. Mood-related disorders have really kind of found their footing in some of the anti-stigma campaigns. We have a lot more people openly talking about their experience with clinical depression, also known as major depressive disorder. We have a lot of people who are talking about, I shouldn't say a lot, more people are talking about things like postpartum depression. More people are talking about seasonal affective disorder. You can get those sad lamps at Costco now. And where we live, we have these long, kind of dark, never-ending winters. And it is so phenomenal that these conversations are happening and we're able to really share that. Bipolar disorder hasn't really benefited as much. There's still a lot of shame attached to bipolar disorder, which is considered more of a serious mental illness. But we have, step by step, we are making some progress here. For any mood-related disorder, they are characterized by disturbances in the way a person feels and in the way the person experiences emotion, and that manifests itself also in behaviors. And so we're going to look at this a little bit. The signs and symptoms of mood-related disorders, so it's something like a depression versus a bipolar disorder, and there are subcategories to bipolar disorder as well, bipolar 1, bipolar 2. When they're active, they make it difficult for a person to function day to day. But there are also inactive episodes. A person, for example, with depression may experience depression at one point in their life. While it may make them more likely to experience an episode of depression in future, there may be years, or they may never experience depression again. Bipolar disorder does tend to be more cyclical in nature, but again, individuals can and most often do have long periods of wellness in between active episodes. This is information that I think is well known, but let's look at it quickly. Depression isn't just about being sad. Sometimes we see stigma-laden language that diminishes the impact of major depressive disorder, clinical depression for people mentioning that the show they watched made them depressed, or this dessert sucks, it's so depressing. It's really important that we think about how we're using language. Depression affects a person's behavior. It has physical, emotional, cognitive effects. It interferes with that person's ability to work and enjoy life, have those satisfying personal relationships over at least 2 weeks. Now that 2 weeks is usually far longer than that before an individual recognizes that this is something that is really set in and is having a negative impact on their life. This is not an exhaustive list of the emotions, thoughts, behavior, physical symptoms that come with depression, but this is to give you an idea of just how devastating this can be for an individual. I'll just, a note here, there are some really great apps that are available. Headspace is a really great app for mindfulness. Folks really, I read a review that somebody said it feels like coming home. They'll use it for a period of time when they feel like maybe they're destabilizing, and then they can kind of take those training wheels off and off they go, and then they'll come back to it. So Headspace is a really great one. Another one is What's Up, not WhatsApp, What's Up, and it uses cognitive behavioral therapy as well as acceptance commitment therapy. So these are evidence-based kind of integrated into the apps. And so those are a couple, and especially What's Up is a free one. I really recommend you take a look at that. Now, bipolar disorder, manic depression. Bipolar is not an adjective. An individual's fashion sense isn't bipolar, the weather isn't bipolar. Bipolar disorder is a serious mental illness. It affects around 1% of the population, so it's not as common as depression or anxiety-related disorders, and is characterized by extreme mood swings. A person has periods of depression and mania with periods of normal mood in between. Now, in addition to all of that stuff that we saw with depression, mania, and it can look different for individuals, but generally speaking, and this again is not an exhaustive list, increased energy, overactivity. With this can come extraordinary creativity, elevated or elated mood, needing less sleep or complete sleeplessness, irritability or physical agitation, rapid thinking, rapid speech, lack of inhibitions, grandiose delusions, lack of insight. For some people, mania at the time can be a really enjoyable experience, but with that can also come a lot of shame. And I recognize we're rushing through some content here, but I think it's really necessary for us to expose our brains to more of what's out there so that we can pique our interest and look more deeply into some of these topics as well. So we're going to move along to anxiety-related disorders. Another one that has really benefited from some of those anti-stigma campaigns. People are talking far more openly about their anxiety disorder. So this is different than the normal level of anxiety that is kind of an evolutionary response for us, that we're able to, run away from mammoths. This is very different than that. This is excessive levels of worry, apprehension, or uneasiness that interferes with our day-to-day living. Again, when we're talking about disorder, we're talking about an interference in the functioning, the enjoyment of life, the engagement with our day-to-day occupational and relational selves for an extended period of time. There are a multitude of psychological and physical symptoms that come with anxiety-related disorders, and it can be a full body involvement: cardiovascular, respiratory, neurological, gastrointestinal, musculoskeletal. When we're looking at panic disorders, so somebody that lives with a panic disorder is somebody that experiences panic attacks. For somebody that isn't used to what's happening, these symptoms, the signs of panic attack, can and do feel very similar to a heart attack, and it is extremely frightening. In addition to panic disorders, there are other, and again, this is not an exhaustive list, there are other anxiety-related disorders that include generalized anxiety disorder. So this is kind of that heightened all day, every day existence. The agoraphobia, the specific phobia disorders that there is really great treatment efficacy for, and social anxiety disorder. It used to be referred to as social phobia. Now, social anxiety disorder is not the fear of being in a crowd. It's sometimes referred to as, I hope I get this right, but the disorder of missing out, of lost opportunity, of missed opportunity. Social anxiety disorder is in fact related to the fear and the concern of how you're being perceived by others, of negative appraisal. And a quick note here about trauma-related disorders. They are related to anxiety-related disorders, but they are different. Fear and anxiety may not necessarily be related to trauma disorders, may not be present. And there are a couple of two prominence here: acute stress disorder, which is the immediate aftermath of an event, and then post-traumatic stress disorder, PTSD, which we hear a lot more of. These aren't only related to combat veterans, to our law enforcement, our firefighters, our other first responders. Trauma-related disorders are very prevalent in, for example, our downtown East Side population, where there are instances of abuse, of early traumatic incidents, of exposure to violence on an ongoing basis. We also see trauma-related disorders in individuals that are not frontliners, but maybe are repeatedly exposed to traumatic materials. So individuals that work, for example, in child sexual exploitation, or individuals that are intervening in suicide. So some of the crisis response work And here, this is for those of you that are working in a space where you are in a helping capacity, or you are frequently exposed to the trauma endured by others. I really encourage you to engage in debriefs and be very aware of the impact to self and the self-care. There can be compound interest over time that we feel it hasn't impacted us this one time, but it is adding up over time. And prioritizing your own mental health will allow you to have your glass full so that there is something to give to others in the future as well. Now, substance-related disorders. These may manifest in negative behavior such as impaired control, social impairment, risky use, tolerance, or withdrawal over time. Those last two are very physiological in nature, but can also be psychological in nature, especially with the draw to the substance. And they differ than substance-induced disorders, and these occur as a direct consequence of intoxication or withdrawal. Cannabis, for example, LSD, cocaine. We might see symptoms of mood, anxiety, and psychotic disorders that all may be induced among other disorders. Crystal methamphetamine is another one. Early days, I cut my teeth in the downtown east side, working as a clinical researcher on a methamphetamine psychosis study. There we were looking at first episode psychosis that was temporally related to the use of crystal methamphetamines. Now, this is where I really wanted to spend some of our time, because this is not a topic that often comes up in mental health introductory conversations and psychotic disorders. There's an intense fear of the unknown. What we see sometimes in media, the coverage that does get picked up indicates more the dangers related to psychotic disorders. And so I wanted to just introduce this because I really feel we have some work to do around stigma and empowering people to engage and intervene early for individuals. Because as we look at earlier intervention for psychotic disorders, we are also then looking at more improved outcomes for individuals that are affected. So what is psychosis? It can be a symptom of psychotic disorder. So a symptom of things like schizophrenia, schizoaffective disorders, sometimes with the mood disorders. So depression, when we have very severe depression, there can also be psychosis with that, or severe bipolar disorder with mania with psychosis. And of course, as I just referenced, substance-induced psychosis is also a concern. Now, there is some loss of reality at times, and there may be periods of relative awareness. There's a misconception that there is a complete departure from a connection to reality, and that's just not true for most individuals who are floridly psychotic. The World Health Organization ranks psychosis, and this is important, as the third most disabling medical condition in the world. So it's considered as a disability. It's just a disabling complex disorder. The risk factors include things like family history, chemical changes in the brain, stress, and a multitude of other risk factors. Again, this is less common than things like depression and anxiety related disorders. Approximately 1% of the Canadian population is affected. If we look at the downtown east side and individuals living with pervasive homelessness and poverty, we do see a much greater representation of psychosis in some of our more marginalized populations. And I think that's really important for us to be aware of, the complexities. Psychosis isn't an on and off switch. It very rarely occurs just kind of out of the blue for the first time. Almost always it is preceded by kind of a gradual non-specific change in a person's thoughts, perceptions, behaviors, functioning. If you know an individual well, you have an adolescent at home, it sometimes can just kind of look like adolescent behavior. But these changes vary person to person, which makes it very difficult to identify. But a skilled clinician who is experienced with psychosis certainly is better equipped to be able to identify kind of, where things are at, what the risk factors are, and protective measures that may be helpful. I do recommend anybody that this is piquing interest for whatever reason for you to visit earlypsychosis.ca. The Early Psychosis Intervention Program is really the place to support individuals who are affected as well as their family, especially for youth and young adults. Now, the basics of psychosis. I'll just give you a minute to look at this. So hallucinations, these are serious distortions of the senses, and these can, be related to any of the senses: visual hallucinations, auditory hallucinations, tactile hallucinations. There can be sense of smell that is impacted for individuals. Really, any of the senses can be involved here, and it can differ from person to person. These delusions, though, these are the serious distortions in the thinking, in the beliefs that really feel real to the individual. And individuals can have difficulty controlling those thoughts, and the thoughts can be intrusive. There are changes in emotion, thinking, perception, mental function, behavioral, and other normal physical health that can look very similar to some of the other mental disorders, mental illnesses that we've looked at. But there also is a lot of comorbidity here. Some individuals that live with a psychotic disorder also do have a diagnosis of, for example, an anxiety-related disorder, or may have experienced episodes of mood disorder as well. Psychosis can cause people to be fearful and to act out of self-defense. This is an important distinction here. There's a misconception that people that live with psychotic disorder are inherently a danger to themselves and others. And this is not true based on evidence. We do know that individuals may, because of the delusions, may attach very negative interpretations of what is happening in the world that does cause them to fear for themselves and for others. And so approaching, and we're going to look at kind of how to approach and what that looks like in terms of getting help for somebody who you believe may be decompensating and experiencing a floridly psychotic episode. And I've already noted that there is more often than not psychotic disorder. There may also be at least one other mental illness. Your personal safety, your level of comfort, your level of knowing what to do in this situation is a really important kind of first step. Psychosis is an emergency, is a mental health crisis. Depending on how well you know the individual, what other resources they have in place, supports that they are already connected with, that is really going to influence how a crisis can and should be managed, and your part in that. Now, assessing for imminent signs of risk of suicide and or harm to self or others, it might be really obvious. They might be standing on the top of an overpass. That's very obvious. That's a 911 call. Where you might have a neighbor who is inside their home and you hear them talking to themselves, you smell burning, you are fearful that they are unintentionally, potentially bringing harm to themselves or others. That may also be an emergency that it requires a 911 call. That unintentional harm to self or others is a really important one to integrate into how you're looking through this lens. Approaching the person in a kind, calm, respectful manner creates that non-threatening atmosphere. Be aware of your body language. Are you in uniform? What does uniform traditionally mean to this person if there has been prior contact with them? Do they have a history of violence? Have they themselves been a victim of crime? Being really cognizant about how you present yourself when a person is in crisis will really influence the outcome. The person may be anxious or fearful. And if they communicate with you that they are afraid of you or that they are suspicious of you, It often is best to remove yourself from the situation and identify somebody else that may be able to intervene. Speaking clearly and in short sentences, repeating yourself as necessary, it might be difficult for the person to understand you. Remember, there might be hallucinations, there might be delusions, there might be racing thoughts. Remaining patient and respectful is really key here. We referenced that individuals may have some departure from reality during psychosis. Don't make promises you can't keep. I'm going to get you an appointment with a psychiatrist. You just, I'll get you in tomorrow. Don't lie. Don't tell them you are not contacting the RCMP if in fact you are. Transparency is important for current trust as well as future trust for when a person is in crisis. If or when you decide to call for help, communicate this, and if it's possible, offer options. Again, they may have connections with a mental health team, with a clinician, and they may pass you their phone and ask you to get on the phone with their clinician who will guide you through what the most appropriate response for this specific individual is. These are still persons, individuals, and us having a person-centered, respectful approach is really critical. Talking about the incident when you're ready. This kind of bounces back to that short reference I made to true trauma. Dealing with mental health crises can be really unsettling and stressful for you if you've been involved. Doubting that you did the right thing. If unfortunately an individual dies by suicide. Playing over in your head what you could have done differently. Debrief is important for your own mental health, even if you don't think it's necessary. I sometimes encourage teams, especially first response teams, to set mandatory debriefs so that individuals don't, for whatever reason, try to self-select out of fear of appearing weak by asking for a debrief, engaging in a debrief. If we make it mandatory, everybody is there, and then it doesn't become a choice that individuals have to be concerned about how they are perceived. Take a look at this. It's absurd. This was an anti-stigma campaign from the Canadian Psychiatric Research Foundation many moons ago. There are a number of these posters. You may have seen them if you took a mental health first aid course or if you've engaged in any of the other mental health literacy campaigns that come from the Mental Health Commission. But this is, when we're talking about mental illnesses, we're reducing stigma. We're recognizing that these are medical conditions. We start to move beyond treating people differently as though they are a problem and looking at what should we be doing better in terms of our engagement, our resources, the treatments that are available, and how people access them. We haven't spent much time together, but you might see some of those myths built into how you arrived today. And hopefully we've taken a little bit of a slide down on that arrow to dispelling some of the common reactions, or at least putting some question marks of, what's next for me? How can I learn more about this? What types of training or exposure to individuals might better equip me, make me more comfortable with things that I currently feel unfamiliar with. So these are the facts. Many people are functioning well within our community, despite a diagnosis of mental illness. People with mental illness are more likely to be victims of violent crime than they are to be a perpetrator. Now, I'm not naive. I, of course, understand, and I work in a threat assessment capacity, recognizing that we do have historical risk factors that we do take into play and do take into account when that is necessary. But in our public safety work, we equally, if not more, I believe, are required to have a commitment to caring for the individual. And that includes persons that are affected, persons they impact, and those who are the individuals that impact others. there is always more to the story, and us caring for individuals must be closely intertwined with our public safety work. Non-judgmental listening and communication increases the likelihood that someone's seeking or accepting appropriate help. Us talking about ourselves, if we are in a team setting and we are in a leadership position, us talking real talk once in a while. I'm not saying you need to spill the beans of your deepest, darkest secrets that you're not yet comfortable talking about. But if we talk more about what is going on for us, our sleeplessness, how we are being impacted, the courses we've taken, the information we're seeking, all of these things, the more that we normalize that, the better we are prepared to accept information, the more likely somebody is going to come to us looking for help, or at least letting us know that they are in need of help so that we can engage the appropriate or other supports. At least 1 in 3 Canadians will experience a mental health problem at some point in their life. This number is probably lower than what it is in reality. And in an average year, at least 1 in 5 Canadians will experience a mental health problem. But if we look back to that research that came out of UBC and the CMHA, we know that 1 in 5, based on our current experience of the pandemic, is exceptionally low. Having these basic mental health knowledge is important when you're assessing how to engage, how to respond, if I should engage, if I should respond to an individual in crisis and in need of assistance. Knowing where to send people in terms of seeking information is also really effective and something that anybody can do. So just a couple more slides here, and then we're going to hear from the constable, and I want to ensure that we have a lot of time to hear from him as well. When we look at mental illness and public safety, social media, we have all experienced the misinformation, how quickly it spreads, how real it looks. It's hard to identify if a source is credible or not. We have deep fakes now. You don't even know sometimes if the individual that you see on screen talking is really and truly them in their own words. But with misinformation and a lack of knowledge or direct exposure to affected persons, there's a tendency to exaggerate attention to the relationship between serious mental illness and violence towards others. In the capacity of threat management, attention should remain on the psychiatric symptoms and associated behaviors. And this information is just for those of you that work in some capacity of maybe violence risk or public safety. We're not worried about the formal diagnosis. It's really about the particular vulnerabilities, the variables that increase risk. What can possibly be protective, and how do we identify those based on that person-centered approach? So looking at past violence, childhood exposure to violence, personality disorder, substance abuse or dependence, numerous other environmental stressors, we are then able to customize and be creative and really be victim-focused, person-centered, aware, trauma-informed with how we try to care for the individual that we are concerned may be a harm to self or others. So mental illnesses are caused by a complex interplay of genetics, biology, personality, environmental factors. Stigma and discrimination attached to these present significant barriers, not only in diagnosis, in treatment, but also in how we accept individuals within our community, where the funds are placed for new services, how we roll out those services, how we communicate them, what languages we offer them in. Approximately 49% of those that feel that they have suffered from depression or anxiety have actually never gone to see a doctor about this problem. So we know that they're not captured in a lot of that data when we're talking about the percentage of individuals that have been affected this year or in their lifetime. But know that mental illnesses can be treated effectively. Notice that we've said treated here, not cured, because those are two very different things. An individual can live a very fulfilling life with great mental health while still being diagnosed with a mental illness. And that's a key takeaway for today. By the age of 40, at least 50% of us will have already had or will develop a mental illness. We know that suicide remains a leading cause of death in both men and women from adolescence to middle age. Death by suicide is higher in men for various different reasons. And we also know that mental illnesses are the most disabling group of disorders collectively that we have worldwide. But there are things we can do. The protective factors, those rings that we can stack on the top of our jars. This isn't fate. There is some control for each of us and in those that we support. So this one is a big takeaway for you today, sleep. It's a complicated relationship, and I think that we all struggle with it, especially if you have a really busy life and family life, work life, live in a noisy place, maybe live with an anxiety-related disorder. Each sleep stage plays a really important role in your brain health. The consolidation of positive emotional content is especially impacted when we have disruptive sleep. And this can therefore influence mood and emotional reactivity, and it's tied to disorders and their severity, including the risk of suicide and outcome. So likelihood of relapse, for example. But we also know that brain activity during sleep has profound effects on emotional and mental health, and that mental health has an effect on sleep. So this bidirectional relationship at times can have us in a cycle of sleep disruption. So sleep disturbances are both a cause and a consequence. And really paying attention to sleep hygiene can be a very protective, effective approach for mental health and prevention of mental illness. So again, happy Mental Health Week. We got a little bit real today, not too real. And I thank you all for being here. It's really uplifting to see so many people signing up for a webinar like this. And I understand from Candace, this is the highest in attendance numbers for any of their webinars to date. And I think that really says something. I look forward to any further conversations any of you have or would like to engage in. Here is one tool that I do recommend. There is a toolkit for people who have been impacted by suicide. So they themselves are a survivor, or you have been impacted by suicide by loss of a loved one. These are really important toolkits for your resiliency, for your healing. Here's my contact information. And I hope in future to be able to see you and engage with you and have really lively conversations. But thank you to technology and thanks to the organizers. And over to you.
Awesome. Thank you so much, Andrea. I know it's been such a tough way to try and fit this much information into one small presentation, but I think you really were able to capture a lot of information and were able to cover a lot of topics that we had requested. So if people are able to stick around, we would love to hear from Constable Shah and hear about his role with the Coquitlam RCMP as a mental health liaison and what that looks like in our local communities. So, and if not, this will be posted eventually. So you can always click on the link once that's posted so you can see that information. And I'll put it over to Constable Shah.
All right. First of all, thank you, Andrea. A very knowledgeable presentation. I love everything that you covered. Thank you, Candace, for the opportunity to be here. And I also quickly want to thank everyone that's viewing this. I personally strongly believe I'm a human being first. As such, I'm a part of your community, and it's my community that's watching. So I want you to kind of put that in the back of your mind. I wear this is just a shirt, you know, and it gives me a certain role, but we all have things, all have roles we play in life. So first and foremost, as a person, I'm going to talk about who I am, what my unit does, partners and people that we work with, and hopefully give you a little bit better understanding of what I do. So my name is Habeeb. I am part of a team of 2 in the mental health unit here with Coquitlam RCMP. For the last year or so, there was actually a team of 1, which was my partner, Scott. And thankfully, we see that as an institution, as a service, we need to evolve. And, you know, while people like me who genuinely care about people and many others that do this job would like the process to move along quicker, we're glad to be here today. And what matters is what do we do starting today and moving forward. And speaking with you is an important aspect of that. So our unit has 2 people. Hopefully within the next few months, we'll have a 3rd, 1 supervisor and 2 officers, 2 constables. So we have quite a broad scope of duties or responsibilities, and that is ever evolving. What that means is we're not just stuck to any one thing, because how would that be fair to you, right? As a community, and as you see as a society, we're constantly faced with new things. This whole COVID thing that's going on right now is an example of that. We've all had to evolve. Well, why should we be any different? So as a person, as a police officer working in this unit, we're always discussing these things. How can we reach out to community? Well, here's one opportunity. How can we go out there? What kind of partners do we need to work with? So people like Andrea, people like Candace, we work with several other teams. I'll bring up what those are. So what I'm trying to say is that we can't do this alone. With as much powers as the police have, we're not the end all. We're just a small piece of the puzzle. And I think everyone watching there, I hope you can be our partners. How you can do that is by communicating with us, is by reaching out to us. And it doesn't have to be when things happen. If you see some of the symptomology or signs that Andrea has discussed, reach out to us, reach out to the various agencies that are available to you to help you. And you know, we're here to help. So some of the things that we do, we have what's called general duty. So police officers that are driving around in their cars, they go take calls, they investigate matters, and often they will attend a call for service for mental health or to check someone's well-being. Once they attend and they take whatever actions, our unit, if it falls into the scope of mental health, will review that investigation and will often take over. Well, what does that mean? So when we take over, we take ownership of it. As so-called experts, what we want to do is say, is this a person that we can help and how can we help them? So that could be short-term help or something long-term. And we'll speak with the individual and or their families. We will speak with various community partners, and what we'll try to do is I call it aftercare, right? So there's this myth out there that just police show up and they do some kind of magic and they take off and that's it. Well, even if that's the case, that's not good enough to me, because mental health isn't something you just solve with one pill or one quick interaction. I wish I had magical powers where I said, poof, you know, your life is going to be great now. That doesn't work that way. We all as adults know that. So my partner and I, we review the files within the Tri-Cities. We will conduct follow-ups with the families, with the people that are involved, with the goal of reducing the calls. Now, that might sound kind of selfish, right? What do you mean reducing the calls? You don't want to deal with these people? No. What that means, reducing the call, is by giving that person help and empowering that person that is experiencing that mental illness and or trauma to find within themselves to recognize their signs and symptoms and reach out for help. And the same goes for their support structure, whether it be their family or caregivers or a mental health worker or various community agencies. And I think that is an important thing. A lot of people think, well, I've got X, I'll call the police and Y happens. Well, no, the best thing I can do as a human being, as a person, is to one, reach out to that person, and two, to provide them with tools where they feel powerful and they gain confidence to say, yeah, even though I'm suffering from this, I can take care of myself. And in those moments that I can't, I know what to do. I know who to reach out to. And I also know to recognize that I'm going down a path where I'm going to need that, right? So that's important. That's that aftercare piece. We also will, from time to time, proactively go out and reach out to, whether it be people at shelters, if we, are aware of someone that's camping out somewhere, suffering from mental health, okay? And we will try and connect with them and see. Often people will say, no, thanks for coming out, but we'll still document it, and we want to be aware of that, okay? We won't just walk away. That's important. Another thing that we'll do is we'll work with the hospitals, we'll work with partners. So if someone's been in hospital for treatment for their mental health and they're about to be released, we'll follow up. And it's just a very friendly call, right? Hey, how's it going? Constable Shah, Constable Klein. We're just calling, we work in the mental health unit. How are you doing? We understand you had a pretty tough experience. It can't be easy. And we do those calls almost daily. Speaking of volumes of calls, I'll tell you, I think, this was a thing that was brought up with COVID. What's going on? Is there like a huge spike of calls? Let me answer that. It's not an easy answer. Yes and no. Having a background in mental health, I can tell you mental health has always existed in our communities. So if you look at Riverview Grounds, which is this huge complex, right? It's this huge, beautiful land. From my research, at one point, there were 4,000 people there. Imagine, just take that for a second, 4,000 people suffering from some form of mental illness that were housed there in all those buildings. And not to minimize this, but pretty much one day, for whatever reason, that was shut down and all these people went out into the community. And there were services available to them and, they were taken care of somehow. But just to show you, that was back decades ago, that there are that many amount of people. So who knows how many thousands of people now suffer from this, but there's no central space to go. And so units like myself and other policing agencies are working with our partners to say, hey, let us take care of the people in our community. Okay, so with that, we work with the Royal Columbian, we work with different hospitals, and we have good understanding, and we help each other out when we can to take care of people. Now, one of the questions brought up to us, well, how do we utilize the RCMP mental health unit when we're working with families, when they know that families are struggling, right? Answered this already, but again, we'll reach out to the family, because one of the things we also consider is that sometimes there's this focus on the people of the people or the person suffering from the mental health, but what about those that are taking care of them? What about mom and dad, or they have a brother and sister at home that are living with them for years? There's got to be some impact to them. So we also try and help out with that. Okay, so there are services. So there's Tri-Cities Mental Health. There's the ACT team. For the elderly, we also have the older adult team. There's numerous agencies that we work with, actually very regularly. Sometimes we talk to them daily. And that's important. So there's a couple of aspects to my unit. There's calls that are coming in that we're reviewing and making sure we have done the right thing. And we hold the people that are going to those calls accountable, if at the least by giving them feedback. Hey, just a suggestion for next time, you may want to look at this. And then there's a proactive side of it where we're going out on the street. So if I wasn't here today, I'd be in the car just driving around. And if a call came in, I would take that call. Or if there's people that we wish to visit, we can visit that. We're also working with our people that monitor statistics here to come up with a list of people where we have a lot of repeat calls and try to help them as a focus, point of attention. Because not everyone's going to be at the same level, not everyone's going to have the same advantages or access to resources, right? Someone that's camping under a bridge is not going to have the same ability to reach out to us or anyone for help as someone that's in a home. So it's not as simple. There's a lot of factors, a lot of variables, and we're trying to meet all of them. Imagine with two people, and I can tell you this, the two people, myself included, have a real deep passion for helping people. I know that sounds really cheesy, but really that's what it does need to be, right? There's all this technical stuff and laws and policies and everything, but that's where our focus is. How do we help this person? Okay. So now it comes to a point of, well, who are we? What kind of people do you have working in your mental health unit? So I just kind of transitioned by saying, we're people that genuinely care, okay? Are we perfect? No. Do we make mistakes? Yes. But we also have an opportunity to learn from those mistakes. We question each other. We will discuss with dialogue. We have community partners who will reach out to us and ask us and engage us, and we're constantly looking for growth. Because without that, we're no good, right? For myself, I've been in this unit now. This is actually my 4th week. Okay, so I'm a baby in this unit. And the process of getting hired on here, I thought, well, it's a mental health unit. How many police officers would be interested? Actually, there was a decent amount. I was surprised. And the competition was quite fierce. I've been with the RCMP for 3 years. Another person that applied was 12 years. Another person that applied was 5 years with the RCMP. So competition was very, very vigorous. And I'm very fortunate and blessed to be here. And what kind of background do I have? Well, so I have very invested in community. And that's what I started this whole thing by telling you, is I'm a person first. Before I was ever a police officer, I've spent 4,000 hours, who's counting, right? But doing community service, victim advocacy, working at homeless shelters. I have a background working with abused children at group home, emergency crisis response, working on crisis lines. So I can tell you that mental health is a passion of mine. Helping people is a passion of mine, and I'm very lucky to be in a position where I can do that. You know, in terms of training, myself and my partner recently have signed up for a 14-week certificate program. You know, I have a certification in suicide intervention. I'm certified in crisis intervention. So there's a lot that goes into this, because I do not take for granted that, oh, because I wear a uniform, I can go in and snap my fingers and magically resolve things. If anything, as Andrea presented, you know, certain things are triggers for people, right? A uniform can be that. So we're also exploring that right now. We're working with our executives to have a uniform, which makes us more approachable while still maintaining that we are police officers, right? So that, because we want to make sure people can come to us and people feel comfortable that we're here to take care and help them, okay, and work with us. So that tells you a little bit about my experience, tells you about our unit, what kind of requirements, what the competition process is like to come in. Just because you've been here 12 years doesn't mean you just get the job. You have to have a passion for this unit. So as a general duty member, whenever I could, I would take those mental health calls. Let me give you an idea. A mental health call typically comes in. We have powers to apprehend the person under the Mental Health Act, go to the hospital. The longest time I've spent at the hospital is 5 hours. That's a long time. And I'm spending 5 hours with this person that's suffering from whatever they're going through at the time. I always took that opportunity to get to know them, speak to them, treat them with dignity and respect. And then, you know, the hospital takes over. So it's quite an involved process. It's not a matter of police just go in and break down, you know, the door and grab the person and take them. And that's an important thing to bring up. There's all these myths of how an apprehension goes, right? There are times where it can be a volatile situation and there's a safety issue. But our foremost is safety of the person themselves, our safety, family, and our public that are around them, and treating them with dignity and respect. Because chances are, if we ever have to go back, well, we can't start that first impression, right? By traumatizing them. So when we go back, our ultimate goal is to make sure, hey, we've established rapport. And I can say with pride that that is something I've attained. in the mental health calls I've approached. Does that mean it's perfect? That will happen every time? No. Again, like I said, there's a lot of stigmas and a lot of things, a lot of myths, but it's up to me, it's up to my partner with each and every interaction that we take, that we embody, what is good, right? At a time where it's really bad for that person and their loved ones. Okay. So those are, a few of the things I want to discuss. Give me a moment to just look at one of the questions we were asked is working with partners to build supports for people in need. Just, Tri-Cities Mental Health, Coquitlam, Port Coquitlam. We work with some of the lodges. We work with Riverview Grounds. We also work with START program, which is for youth. We work with the Crisis Center, Crisis Lines. We also have our in-house victim services as a resource, because we don't know all the answers. We don't know every agency that's out there. There's a lot of grassroots organizations doing great work. And I think having that humility, knowing that we're not the end all, that we're just one piece of the puzzle. We'll have other agencies sometimes contacting us, asking us things, and there's nothing wrong in saying, hey, let us get back to you. So I'd like to close off with saying that we are in a process of growth. We are in a process where we listen, where we're constantly looking to evolve, to change for the better. Oddly enough, COVID has given that opportunity because while mental health calls are up, we're dealing with sometimes 50 a week, okay, just to give you an idea. It has also given us an opportunity to be better. And the only last thing I'd say is everyone watching that still stayed here, thank you for staying, is to please consider working with us. We're open to feedback. We're open to constantly growing, and reach out if you or someone you care for is suffering from any mental health conditions, and take care of yourself too. That's one last thing I want to say is no matter what you do in life, if you're taking care of others, if you're there for others, please take care of yourself. That's pivotal, because then that'll also empower you and enable you to continue giving care to others. And same goes for us. So that's what I have for today. I want to thank everyone for listening, for being here, and for being engaged as community members. We can't do this without you. We can't do this alone. Like I said, as much power as we may have, we are powerless without the public. And we thank you for believing in us and supporting us.
Awesome. Thank you so much. Time has really flown, and I know we have gone a little bit over what some people's lunch hours might be, but we do appreciate your time and spending more of that with us. This, as we said, is a very complicated topic, and we have only touched the surface. And there was so much to take away and learn from this that I think as long as you've taken one thing, we've done our jobs, and we've satisfied hopefully this topic. And there are so many resources. So I think we can put those up on the screen here that will maybe help navigate the mental health support system as you're going through this journey of learning more, and just trying to see where else you can get some supports and some help. And again, I just want to thank our speakers of Constable Shah and Andrea. Again, we couldn't do this without you, and really in the community police world and in our substations here, we're a resource for you. So we also have these resources on hand. We share them with the public and try to get resources connected, because this is a community problem, and it is something that we all need to work on together. And this is something that we're really pushing for and forward. If you do have any other questions, again, our website, our email is on this screen, so you can email us at coquitlam_cpu_webinars and ask us some more questions. And you can also follow us at Coquitlam RCMP on Twitter and Facebook, and this will show our next webinar, and we will have some more coming up for you, so you can learn about some other community safety and crime prevention topics. topics. So I just want to thank everyone again. Thank you to participants, panelists, and the Crime Prevention Unit to be able to put this on. And we hope to see you next time.